Hello everyone, today I am going to start another topic of pharmacology, that is insulin and oral anti-diabetic drug. जब भी insulin की बात आती है, from where this insulin comes, it comes from the pancreatic gland. So this is the gland which is having both the part, both exocrine and endocrine gland. The only gland which is having both exocrine and endocrine tissues, it is only the pancreatic gland. This is very important MCQ. And who has found that two type of tissue they are found in the pancreatic gland? It is found in 1869 by a German student, that is Paul Langerhans. He is the one who found that in between the acinar tissue there are scattered islets, which he say islets of Langerhans, and this is the one which is going to secrete the digestive enzymes, and this is the one which is going to secrete various hormones. So Paul Langerhans, he is the one who discovered the two type of tissues, but who discovered the insulin, that is by Benting and Best. They are the one who discovered in 1921 insulin. So in between this 1869, Paul Ehrlich, he told pancreas, it consists of two type of tissue, and discovery of the insulin. In between this there are many things which happened historically, and then in pure crystalline form this insulin, it was obtained in 1926, and chemical structure that is given by Sanger in 1956. So let's see about the insulin or pancreatic gland, sorry. So this is the pancreatic gland. So you can see the acinar tissue, this whole thing, it is a acinar tissue which is going to secrete the digestive, the exocrine part, this one, and in the endocrine part you can see the pink cells, then gray cells and a blue cells. So maximum number that is of a pink cell. So this pink cell, they are the beta cell. Their number is about 75%, 72 to 75%, they are the beta cells. So beta cell, they are the one which is going to secrete the insulin and another enzyme, that is another hormone, that is a amylin. So these are the insulin, proinsulin and amylin. Then another cell in this islet of Langerhans, another cell is alpha cell. This constitute around 20 to 22% of the cell, and this alpha cell, they are going to secrete what? Glucagon. See here, insulin, C peptide and proinsulin. And then a small amount of this blue color cells. So you cannot see here because of my face. So this blue color cell, I'll highlight this. So this blue color cell, this is around 2 to 4%. Okay. This is around 2%. They are the one which is going to secrete the somatostatin. So 2% of, this is a delta cell. ये आपके delta cell. And there are another cell, that is pancreatic polypeptide cell, which is going to secrete the pancreatic polypeptide. So you can see from the pancreas with the exocrine part, which is going to give the digestive enzymes, and from the endocrine part, this consists of beta cell, maximum number 75%. From here comes insulin, amylin, 20 to 22% alpha cell. From this is going to give the glucagon, and 2%, that is the delta cell. This is going to give the somatostatin, and pancreatic polypeptide cell, which is going to secrete the pancreatic polypeptide. Now how this insulin, it is synthesized, जो यहाँ पे है, this within this cell, how this insulin, it is synthesized within this cell. It is synthesized, you can see here in this, it is going to secrete what is releasing This from the beta cell, what is coming? Insulin, C peptide and proinsulin. So all the three. So how this insulin, it is synthesized within the beta cell. It is synthesized as a pre-proinsulin, as a single peptide chain, pre-proinsulin, which constitute 110 amino acid. So from this 24 amino acid, they are removed, and remaining 86 that constitute proinsulin. Now this proinsulin, it constitute A chain, B chain. You can see it constitute A chain. This side you can see the structure. So A chain, B chain, and here this is a C, that is connecting peptide. Now if we remove this, then what remains? A and B chain. So with the removal of this connecting peptide, which constitute 35 amino acid, then what we get? We get the insulin. Insulin with 51 amino acid. So this is the insulin with A chain and B chain, which is bound by the disulfide bond. And now there is no connecting peptide chain in between this. So in the beta cells, we have all this proinsulin, insulin and C peptide, all they are together. So all of them, they are released also. Synthesis happens within the insulin, and then this 51 amino acid, out of this A chain, it constitute 21, and B, we write B this way. So remember 30 amino acid in B chain, and with A chain there are 21 amino acid. This is how it is synthesized. So it is synthesized, then how it is secreted? Insulin, ये secrete कैसे होता है? What are the factors which are going to affect its secretion and its mechanism of secretion? How it is secreted? It is secreted in pulses. Biphasic secretion, that is there. Biphasic secretion is there. You can see here it is biphasic, first phase and a second phase. In a first phase, you can see this normal. So first phase mein, the peak it happens within 1 to 2 minutes, and this is the second phase, and it remains there for 5 to 6 minute half-life. And what are the maximum? How it is this? Even at rest also, there is a basal condition, 1 unit of insulin that is secreted every hour. So 1 unit, it is equal to 40 microgram, because 28 unit it constitute 1 milligram. Okay? So 28 unit it constitute 1 milligram or 1000 microgram. So 1 unit constitute 1000 by 28, it comes around 40 microgram. Okay, so it is secreted in pulses, biphasic, that is the first and second. And you can see in the type 1 diabetes there is no phase, and in type 2 the phase 1 that is missing, and you can see the phase 2. Then second one is, what are the factors which are going to regulate its secretion? Like chemical, we take the food, so glucose, that is the main, even amino acid, fat, they also cause the release of insulin. Glucose, how much glucose is required? More than 70 milligram per deciliter, they are going to stimulate the insulin release. Then hormonal and neural, there are the many, but this, if you remember, just now I have told the islet of Langerhans, we have 3 type of cells. कौन सी है? Beta cells, alpha, mainly delta, pancreatic polypeptide, you just leave that. So insulin, from here insulin come, from here come glucagon, and from here come somatostatin. So somatostatin इधर कर लो, ठीक है? Somatostatin, insulin and glucagon. Okay. Now somatostatin, it is going to inhibit all. Here you write even pancreatic PP also, pancreatic polypeptide. So somatostatin, it is going to inhibit all the three, right? Whereas glucagon, it is going to stimulate somatostatin as well as insulin. And insulin, it is the opposite action with the glucagon. This is how the hormonal level they are regulated. Then coming to the neural, this is one picture I'll show that this is biophysics how it is regulated. So this is the chemical, all the glucose fatty acid they are going to cause stimulate the beta cell, and you can see here plus plus plus, so they are stimulating the release of this, so all big plus. So this is a, and then hormonal from the glucagon positive, somatostatin negative, okay, and then comes the this neural, the two main system, that is a sympathetic and a parasympathetic. So parasympathetic nervous system, you can see here also parasympathetic, that is a positive, it is going to cause stimulate of beta cells and that there is a release of insulin. Whereas a sympathetic mainly the alpha 2, that is going to inhibit, whereas beta is going to stimulate this, but beta it is a minor action, and this alpha 2, this is a major action. Then GIT hormones, they are also having the positive. So what are the factors which are going to regulate the insulin secretion? I haven't covered all the factors. There are many drugs which causes the release of insulin, many drugs which inhibit the release of insulin, so you will be reading in a various chapter. But so far is chemical, the best is glucose, then hormonal, all this somatostatin and glucagon, then a neural, sympathetic and a parasympathetic nervous system. Now once it is this secretion, what is the mechanism of secretion? See, it is synthesized as a proinsulin and insulin, and it is stored, it is there. And what are the factors which is going to regulate its secretion? Suppose if it is a glucose, it is going to cause the release of secretion, but what is the mechanism, how that glucose it is going to cause the release of this insulin secretion? Let's see in the next figure. This is how hormonal regulation. Okay, so this figure, this illustration I have taken from the Pharmacology book by KD Tripathi, so you can see figure in that book. So here I'm just going to tell this is a pancreatic beta cell. A pancreatic beta cell, they have shown it. So if you are going to take the glucose, now this glucose, it will enter within the cell, pancreatic beta cell, and it get metabolized by the glycolysis, as you read in the biochemistry. With the glycolysis, what is the end product of the glycolysis? It is a ATP. There is a generation of ATP. Now in the pancreatic beta cells, there are ATP sensitive potassium channel. What are they? They are ATP sensitive potassium channel. So whenever there is a release of ATP, when there is a generation of ATP, they are going to block this channel or close this channel. You can see here in this figure also closing ATP sensitive potassium channel, and this ATP it is going to close. Now potassium, it is a intracellular ion. इसकी tendency क्या है? The inside potassium it is more. If this channel is open, there is outward movement of the potassium. But now the channel it is closed. Now what will happen? This outward movement, this is also inhibited. Now where potassium will be there? Potassium will remain inside. You can see increase in the potassium level, and this is going to cause the depolarization of this beta cell. Okay? it is going to cause a partial depolarization, you can see. And this depolarization or slight depolarization, what it does, it is going to cause the opening of this calcium channel, and there is an influx of the calcium channel. And this calcium, what it does, it is going to cause this fusion of vesicle where the insulin is stored with the pancreatic beta cell membrane, and there is a release of insulin. Okay, so this is a one way. Another way is, now this glucose you have taken it orally. So whenever you are going to take any oral thing, this is going to cause the release of incretins. Now, what are incretins? So incretins are the gut hormones which are released in response to the food. So what are the incretins? They are the gut hormones which are released in response to the food. So here, what are the incretins? These, they are the incretins. GLP-1 and GIP. GLP, that is glucagon-like peptide. What is GLP? GLP-1 is there, GLP-2 is there. So glucagon-like peptide 1. Whereas GIP, that is glucose dependent or stimulated insulinotropic peptide. Okay. So incretins, they are the gut hormones which are released in response to the food, and these are the GLP and GIP. Now what they do, they are going to act through the receptor, and receptor, they are present at various sites. One of the site, that is a pancreatic beta cell. It is also present on the alpha cell. Now if it is going to act here on this receptor, this pancreatic beta cells, incretin mimetic receptor. So incretin mimetic receptor, they are what kind of receptor? They are G protein coupled receptor. You can see here in the figure. So they are G protein coupled receptor with the second messenger, that is adenyl cyclase. Now this is going to stimulate the adenyl cyclase, and this is going to cause the conversion of cyclic ATP into cyclic AMP. Now this cyclic AMP, what it is going to do, it is again going to cause the fusion of this membrane with this, and there is a release of insulin. Okay. So insulin release, how the glucose, it is going to cause the release of insulin from the pancreatic beta cell. You can see with the both way, by closing the potassium sensitive ATP sensitive potassium channel, and by causing the release of incretins. That's why when we are going to give the oral glucose, it is going to cause the more release of insulin as compared to the parenteral, because with the oral there is a release of incretins that also happens. Now once this insulin, it is released, okay, now it is released in the circulation. Now how it is going to act, what is the main action of that insulin, and what is the mechanism? This is a mechanism of secretion. The insulin, this is synthesized, it is stored here. यहाँ पे आपकी stored है. It is synthesized as a proinsulin, then insulin with the C peptide, and it is stored. Now how it is released? Okay, how it is released? Once it is released, it comes in the circulation. Now what is its action? How it is going to perform its action? It is going to bind with its receptor, which are present at almost on each and every cell, and maximum number of the insulin receptor you can see on the liver cell and minimum on the vascular endothelial cell. Now what kind of receptor? The insulin एक बार जैसे आगे, its main action is to make the cell to utilize and store. Utilize what? Utilize all the nutrients. Glucose, because you have taken the food. Glucose, you have taken the meal, and insulin that is released. Now what is the action of this insulin? What is the purpose of this insulin? It is going to make the cell to utilize or this glucose, fat and protein either utilize or take it up, and reuptake will be there and it will be stored. Now, what is the mechanism of action of this insulin at various receptor? So you can see the receptor, the insulin receptor, it is heterotetrameric. It is a, you can say, tetrameric receptor. Tetrameric is, that means there are 4 peptides. There are the 4 subunits of this receptor. 4 subunits कौन से? 2 alpha and 2 beta. So 2 alpha you can see it is a extracellular and this is a transmembrane. Okay? So alpha unit it carry the insulin binding site, whereas beta subunit it is having the enzymatic activity. Now it is a tetrameric receptor, then it is a enzyme linked receptor or tyrosine kinase linked receptor. You can see this tyrosine here and here. Once the insulin it binds with the receptor, then what will happen? This receptor it is going to cause the phosphorylation of this enzyme tyrosine. So once they are going to cause a phosphorylation of each other, this is going to cause a phosphorylation of this and this is going to cause a phosphorylation of this. This term it is called the autophosphorylation. Now once the autophosphorylation that happens, then what will happen? It is going to cause the phosphorylation of various other protein. Now most important here is insulin receptor protein. It is going to cause the phosphorylation of insulin receptor substrate, not protein. It is insulin receptor substrate. So insulin receptor substrate, they are present at various sites depending. There are many type of insulin receptor substrate depending on the tissue. So it varies from tissue to tissue. Now once this get phosphorylated, it is going to cause the phosphorylation of many other things. So the most important is it is going to, now this insulin it is going to act mainly at 3 level. I'll just let me finish first this one. So this phosphorylation it is going to cause a further phosphorylation of what? It is a phosphatidyl. This is not P13, it is a phosphatidyl inositol 3 kinase. Okay, so it is going to cause a phosphorylation of this phosphatidyl inositol 3 phosphate 3 kinase, and this is going to start the cascade like of this phosphorylation and dephosphorylation of many. एक बार अगर kinase word आ गया, that means it is going to add the phosphorylation. And the most important is what it is going to cause. It is going to cause the activation and inhibition of the enzyme. Activation of what enzyme? Activation of the enzyme which is going to cause a utilization of the which is going to cause a utilization of the like carbohydrate, fat and glucose, all the metabolic activity, the enzyme metabolism of carbohydrate, fat and protein. It is dependent on whatever kind of enzyme. So this is going to activate that, okay, or inhibit depending on that, which is going to, so all the metabolic function will be exerted. Second one is this is also going to cause a phosphorylation of the second messenger. Here it is hidden. Now which second messenger? It is PIP2. There is a generation of this PIP2, phosphatidyl inositol 4,5 diphosphate. Now what is the action of this? This PIP2 it is going to act on this. What is this? This is a GLUT4. What is that GLUT4? You just GLU. This is glucose and T is the transporter. They are the one which is going to cause the transportation of the glucose. Okay. Now this GLUT4, it is present within the cytosol. Now what this is second messenger PIP2 it is going to do, it is going to cause the translocation of this GLUT from the cytosol towards the membrane. You can see here towards the membrane. Now this GLUT, it is going to, what is the function of this? This is going to help in the uptake of the glucose by the cell. So there is a translocation of the GLUT4 from the cytosol towards the membrane so that the uptake of the glucose will happen. This is the second function. And the third function of the insulin, that is at the nuclear level. Just see how it is going to exert the action at the nuclear level. That is again with the phosphorylation of this RAS and MAP kinase, and this is going to cause the transcription. This is going to act on the nucleus and transcription will happen. Now with this transcription, what will happen? Translation will happen, and there is a various proteins, they are synthesized, which are going to participate in the proliferation and differentiation of the various cellular function. And out of that, what is another, this transcription and translation, they are going to also cause the synthesis of this GLUT4. So GLUT4, it is also synthesized with this, with the transcription and translation, and also transported. So insulin, it is going to act immediate action, that is activation and inhibition of, this is number one, the enzymatic activation and inhibition of the enzyme. Then intermediate action, this transport of this GLUT4 from the cytosol towards the membrane. And number three is this at the nuclear level. So ultimately, what is the action of insulin? It is at three sites, 1, 2 and 3. So its main action, that is basically on the three metabolism, carbohydrate, protein and a fat at three important tissue, that is a liver, skeletal muscle and adipose tissue. Its main action is, agar hum le glucose ko, so its main action is to increase the glucose uptake. Uptake hone ke baad, what it is going to do, either it will be utilized or stored. It is utilized or stored, and there is it is going to decrease the breakdown of this. The glucose production, that is decreased. Similarly, if I take up, so this is the carbohydrate metabolism. What about the fat and the protein? It is going to the breakdown of the protein and fat, that is also decreased, and increased lipogenesis and increased uptake of the protein will be there. Just see the next slide. So liver, muscle and adipose tissue, all the three sites and the three metabolism. If you take up the carbohydrate or glucose, it is going to increase the glucose uptake and glycogen synthesis. Same muscle, they are going to use the glucose uptake and utilization. Here also glucose uptake and stored as a fat and glycogen. Okay. Then in the liver, because it has to decrease the level of glucose, so it is going to inhibit the glycogenolysis. Glycogenolysis, that is breakdown of glycogen into the glucose. So it is going to inhibit, usko ye inhibit karti hai. Then gluconeogenesis. Now gluconeogenesis, this is a synthesis of the glucose from amino acid, pyruvate, free fatty acid and glycerol. So it is going to inhibit that. So ultimately it is going to decrease the level of glucose. Then in the muscle, the first carbohydrate I have told, then it inhibits the proteolysis. So by inhibiting the proteolysis, now amino acid won't be, there will be no regeneration of this. It is not generated. So it is not utilized in the gluconeogenesis, and release of amino acid, pyruvate, lactate, which is a substrate for gluconeogenesis. Ultimately, it is going to inhibit that. Then it inhibits the lipolysis also and release of free fatty acid and glycerol, which is the substrate for the gluconeogenesis. They are the main action of the insulin. Now insulin, it is a helping in the, so kai bar kya hai, like they say कि insulin, its main action is only on the carbohydrate metabolism. No, it is going to take care of the metabolism of fat as well as the metabolism of protein. So if there is a deficiency of this insulin, agar ye kam ho jata, if there is a deficiency of this insulin, then what will happen? All the metabolism, glucose or carbohydrate metabolism, fat and protein, all will be impaired. So that leads to the diabetes mellitus. So insulin deficiency, that leads to the diabetes mellitus. So diabetes mellitus, what is that? It is a metabolic disorder. तीनों के तीनों आपके होंगे. So carbohydrate metabolism, lipid and protein. So these are the things. There will be hyperglycemia, glycosuria, hyperlipidemia and negative nitrogen balance, and patient will come with the symptoms of polydipsia, polyphagia and polyuria. See, there is a hyperglycemia. Because of that hyperglycemia, what will happen? The glucose, it will be filtered at the proximal convoluted tubule and it won't be reabsorbed because more glucose that is there, and that leads to this glucosuria. Hyperglycemia, this leads to glucosuria or a polyuria. Now, because of this osmotic diuresis, patient will feel thirst. Polydipsia means increased thirst. Polyphagia is no, the cell, they cannot take up the glucose, they cannot take up the nutrients. Then what will happen? Cell starvation will be there and patient will end up eating more. So this is the cause of polydipsia, polyphagia and polyuria. Now, how many type of the diabetes mellitus they are there? I am going to take up only two type of diabetes mellitus, type 1 and type 2. Mainly it is of type 1 and type 2. Now, what is the basic difference between the type 1 and type 2 diabetes mellitus? Type 1, which is very commonly we say insulin dependent diabetes mellitus, and this is a non-insulin dependent diabetes mellitus. So this tells about the pathogenesis, type 1 and type 2, and this tells about the physiological mechanism like insulin dependent and non-insulin dependent. This is ketoacidosis prone and this is non-ketoacidosis prone. And type 1 and type 2, they tell about the pathogenesis, like this is a immune mediated, autoimmune mediated, and this is a main cause here. It is a obesity or insulin resistance, that is the main cause. So here the type 1, that is idiopathic or autoimmune, that means the antibodies they are developed against the pancreatic beta islet. Antibodies they are developed against the pancreatic islet and they are destroyed. So 70 to 80% of the islet they are destroyed and there is near complete deficiency of insulin and low genetic predisposition, and triggering factor is viral infection or toxic chemicals, and it is mainly associated with the ketosis. Whereas on the other side we will say the common risk factor, that is the obesity, and this obesity it leads to the insulin resistance. Okay, this obesity it leads to the insulin resistance. So ultimately her main cause in the type 2 is insulin resistance. So the cell mass that is normal or there is a slight reduction, insulin level isme there is a complete deficiency or near total, isme it is a variable depending on at what stage patient has come. There may be, if the patient comes initial stage, there may be hyperinsulinemia, and later on there will be less insulin and insulin resistance that is there. It has got high genetic predisposition. Now, how to treat, how to diagnose it and how to treat. How to diagnose, with the diagnosis of the diabetes mellitus. So diagnosis is, you can see here, the normal, this is a fasting blood glucose level and this is the postprandial glucose level. Two-hour glucose level, and this is a glycosylated, that is HbA1c, glycosylated, this one. So fasting blood glucose level normal, it should be less than 100 milligram per deciliter. 2-hour, it should be less than 140 milligram per deciliter, and glycosylated should be less than 5.6%. In diabetes mellitus, you can see if it is more than, and if it is more than 126, then we will say patient is having diabetes mellitus. And 2 are postprandial. If it is more than 200, we will say it is a diabetes mellitus. And if it is more than 6.5, then it is this. If it is more than 6.5, it is a diabetes mellitus. So you know the normal level and you know the diabetes. So in between comes a pre-diabetic. Between 100 and 126, 140 to 199 and 5.7 to 6.4. So that is pre-diabetic. So pre-diabetic, if the person takes good control, this can be shifted towards this side. If a poor control, then it will be shifted towards this side. Now what to do? What are the treatment of this diabetes mellitus? So there are the various drugs which are there, various regime which tries to achieve the euglycemic. So round the clock euglycemia, that is more important rather than intermittent euglycemia, because to prevent the diabetic complication you need to have a round the clock euglycemic effect. Now what are drugs we have? Anti-diabetic drug. So anti-diabetic medication, how we are going to classify? So depending upon its mechanism of action, we classify mainly the drugs which are going to increase the insulin secretion, okay, which is going to cause the increase in the insulin secretion. The drug which are going to reverse the insulin resistance or decrease the insulin resistance, and which are going to decrease the absorption of the glucose, and the drug which are going to act by various miscellaneous or the newer drug. So what are the drug which is going to act by increasing the insulin secretion? And we call this group of drug insulin secretagogues, and they are further of two type, parenteral and oral. Rather it's better if I write here oral parenteral and oral. Okay, so oral is further of sulfonylurea, we categorize this one as a sulfonylurea, and DPP4 inhibitors. Sulfonylurea, they are further of two type, first generation and second generation. They are first generation and second generation. Now in the first generation we have two drugs. One is tolbutamide and we have chlorpropamide. Whereas in the second generation we have glibenclamide, glipizide, gliclazide and glimepiride. So these are the sulfonylurea group of drug. Then in the parenteral we have GLP-1 analog. Now what we have here, exenatide and liraglutide. Now what we have under DPP-4 inhibitor, here we have a gliptins, sitagliptins, vildagliptins, linagliptins, allogliptins. So they are gliptins. इसको हम क्या बोलते हैं? They are all end with the gliptins. ये आपके जैसे exenatide and this one, ठीक है? So and this second generation all start with the GLI, GLI, and end with ide. Now coming to how this group of drug they act, we'll take up first the sulfonylurea group of drug. So sulfonylurea group of drug, then one more is there, that is a oral में one more, Miglitinides, and under the Miglitinides we have ripaglinide and natiglinides. These are the two drugs. So anti-diabetic medication, how we are going to classify the one which is going to increase the, I have just taken one. So mechanism of action पता लगता है. They are going to, what is the classification depending on the mechanism of action? These are the drugs which are going to increase the insulin secretion. अब insulin secretion कहाँ से होगी? Pancreas से. So that means pancreatic islet should be intact. Some number should be there for the action of this group of drug. So they are further classified into parenteral and oral. So this is we have to give by subcutaneous route. This we can use by oral route. And the first drug, that is sulfonylurea, or how they are going to act. So again the same figure. So you can see in the same figure this SU and Miglitinide. So that means, and this is a SU, or what is this? Is a sulfonylurea receptor, and where they are there? So sulfonylurea receptor, they are present on the ATP sensitive potassium channel, and where this ATP sensitive potassium channel, they are there on the pancreatic beta cells. Now this ATP sensitive potassium channel, normally it is blocked by what? ATP. Increased ATP, they are going to close this ATP sensitive potassium channel. Now this action, it is performed by this group of drug. कौन सी? This sulfonylurea and miglitinides. What they are going to do? They are going to block. You can see SU, it stands for sulfonylurea, and MEGLI, this is a miglitinide. So both of these drugs, they are going to act here on this receptor, and they are going to block this potassium channel or close this potassium channel. So what action ATP was doing here? ATP, it was blocking this potassium channel. Now this group of drug, they are going to block this channel. If this channel, it is blocked, then what will happen? There is increase in the level of potassium, which leads to partial depolarization, and this is going to cause the opening of this calcium channel, and there is a influx of the calcium, and this is going to cause a full depolarization. Depolarization will happen. This is going to do what? The fusion of this membrane with this, and there is a release of insulin. So that's why this group of drug, they are called insulin secretagogue. इसको हमने क्या बोला? Insulin secretagogue. They act by causing the release of insulin. ये दोनों के मैंने आपको mechanism बता दिए, sulfonylurea and miglitinide. So whatever sulfonylurea group of drug, whether it is a first generation or whether it is a second generation, they are going to, all of them, their mechanism of action is same. They are going to block the ATP sensitive potassium channel. By blocking that, they are going to inhibit this outward movement of the potassium, and there is increased level of potassium inside, that leads to depolarization, and this depolarization leads to opening of, so number one is they are going to block or close this channel. Number 2 is level is increased, depolarization, opening of calcium channel, then again depolarization, 5th, and then there is a fusion and there is a release, right? So this is how they are going to act. What is the differences between this tolbutamide, chlorpropamide? So here important thing which you must know. So for their action, a certain amount of beta cell that should be there. So all they act, mechanism of action of all the sulfonylurea, that is the same. And all of them, they need 30% of the functional pancreatic beta cells, right? Now how they differ, mechanism of action. So their difference is basically, so this is a one mechanism of action, how they are going to act, sorry, and second is this is on the pancreatic beta cells. Now how this drug sulfonylurea and miglitinide on the pancreatic beta cell, whereas on the extra pancreatic they are going to increase this insulin. It is going to act on various receptors, so they are going to increase the number of receptor and they are going to increase the sensitivity of the receptor. This is another. And glimepiride and gliclazide, they have antioxidant action and hepatic degradation, that is also slowed with this group of drug. Now here important question is, with sulfonylurea after few months, because they are going to, how they are going to act, they are going to cause the release of insulin. So insulinemic action, it declines, because when you are going to use it for the years, for few months to years, 1 year, there is a down regulation of this sulfonylurea receptor. That is the cause, down regulation of sulfonylurea receptor. So that is going to decline this insulinemic action. But still the glucose tolerance, there is improvement, that is still maintained. Okay. So what will happen? There is now, you have started giving the sulfonylurea, a group of drugs. Suppose patient is taking glimepiride, or patient is taking glibenclamide, patient ने लेना शुरू कर दिया. Now we are using it in a type 2 diabetes में. हम इसको किस में यूज कर रहे हैं? Type 2 diabetes mellitus, where we say main cause is obesity that leads to insulin resistance. If there is a resistance, that is going to cause a hyperinsulinemia. Now what happens once you are going to give this drug? Then what will happen? There is improvement in the carbohydrate tolerance, and this improvement in the carbohydrate tolerance, this hyperinsulinemia, this is going to decay. And because of this hyperinsulinemia, what will happen? There is a decrease, apparent decrease in the number of the hyperinsulinemia, insulin ज़्यादा हो गया, decrease in the number of insulin receptor at various sites. Now with the sulfonylurea group of drug, now carbohydrate, there is improvement in the carbohydrate tolerance, and that is going to decrease this level. इसको काम करेगी hyperinsulinemia, and there is an apparent increase in the number of insulin receptor. Because of that, the improvement in glucose tolerance, that is maintained, though the insulinemic action of sulfonylurea group of drug, that declines. Now all of these drugs, they are given by oral route with the peak plasma concentration. They are attained in 2 to 4 hours, bound to plasma protein. Volume of distribution, that is 0.2 to 0.4 liter per kg. It is metabolized in the liver, excreted in the urine. Half-life, there is a variation they are seen in the half-life, and even the duration of action, that is also varies. So there are a few common points in all the sulfonylurea. What are the common points? Their mechanism of action. All they act in a same way. Then second thing is, all they need at least 30 to 40% of intact functional pancreatic cells. Functional, we need to have functional islets, that is required. Okay? Now what else? Then how they differ? इसका मतलब अगर किसी में पैनक्रियाज नहीं है then this group of drug it is of no use. जिसमें functional islet नहीं है then this group of drug should not be prescribed to that patient. It is totally useless. Then what are the differences? How they differ? They differ in potency. Potency किसी की डोज कम है, किसी की डोज ज़्यादा है. Then on half life, then adverse effect. So potency you can see in the next figure. This also I have taken from the Tripathi. So here you can see the dose per day, and just this is a sulfonylurea group of drug up till here. So you can see the dose potency. Okay. With the potency then you can see the duration of action also. Tolbutamide, the minimum duration of action, and the maximum is with the chlorpropamide, that is not given. To chlorpropamide, it acts more than 24 hours. First generation. So first generation tolbutamide. Then we have another drug, that is a chlorpropamide, whose action is more than 24 hours. It is a more than 24 hours. And you can see duration of action lowest, that is with the tolbutamide, and whereas rest of glipizide, that is another one. And then another thing which you can see, the plasma half-life. All of them, they are metabolized in the liver. Plus various little bit differences you can see here. Tolbutamide, it is you can see the because of less duration of action. Duration of action is 6 to 8 hours. So hypoglycemia it is less. So we can use safely in a elderly patient. Then glibenclamide, it is a potent but slow acting, higher incidence of hypoglycemia because of the hypoglycemia, that is the most common side effect which is seen by this group of drug, because they are going to cause the release of insulin, and insulin का भी सबसे important side effect क्या है? Insulin का the most common side effect is that is hypoglycemia. Same side effect that is seen with this group of drug, sulfonylurea group of drug. So hypoglycemia, then single daily dose we give. Though the half life, इसमें क्या half life सभी की number of half life it is less, you can see, but duration of action that is there. So half life though it is less, but we give a single dose. Then if you want fast short acting, higher daily dose to be divided, hypoglycemia and weight gain they are less likely, and we prefer this one in a elderly. Glycoside, glimepiride, long acting, only inactive metabolite, that is, and a stronger extra pancreatic action, where the number and sensitivity of the insulin receptor that is seen with the glimepiride. So you can see this also, refer this table. And so differences, that is, so need, if the person needs once a day drug, glibenclamide. Young patient, glibenclamide and glipizide. Elderly or those who are prone for the hypoglycemia, जिसका short duration of action है, like glipizide and tolbutamide. When we need a potent, faster and shorter acting, glipizide. Patient prone to weight gain, gliclazide or glyclazide, right? So potency it varies, half-life this varies. Now coming to the adverse effect, the common adverse effect with almost all the sulfonylurea group of drug, that is hypoglycemia, and the second one is a weight gain, almost with all the second generation and the first generation. This is seen almost with all first and second generation. सिर्फ इसके साथ glycoside that does not show the weight gain. So where we do not want this one, so we can put the patient on that. Now adverse effect with the first generation like tolbutamide is a slight variation, that is you can see with the tolbutamide. So tolbutamide, it is glutamide it inhibits the reuptake of iodide. But hypothyroidism, there is a rare chances of hypothyroidism is seen with this. Then it also shows the zero order kinetics. So this is the difference between this with the other. Then another one is chlorpropamide, another. So this is the longest acting, the maximum hypoglycemia that is seen with this. And it starts with the C. It also shows another cholestatic jaundice, maximum hypoglycemia, then intolerance with the alcohol. So it is showing the disulfiram-like reaction. So whenever you are putting this drug to the patient, ask the patient or ask the person not to consume alcohol. And another one is it increases the ADH release or antidiuretic hormone release. And if this is increasing the ADH release, that means it needs antidiuretic. So diuretic nahi hone dega, it increases or causes ADH release. Antidiuretic agar release ho gaya, then it is going to cause what? Dilutional hyponatremia. एक ये हो जाएगा पेशेंट को. And we can use this one also in the diabetes insipidus. So the drug which we can use both for the diabetes mellitus and diabetes insipidus is we have chlorpropamide. Okay, so during pregnancy we cannot use this, and it is secreted in the milk. So during lactation also we cannot use. So I have told you the common points. Common points इसमें क्या हो गया? This is also comes under common point. So we mechanism of action that is same. All of them they act by causing the release of the insulin. Then for the release, we need a 30% of the intact islet cells. The functional islet cell should be there. So common side effect, hypoglycemia and weight gain. Then tolbutamide and chlorpropamide, they exert their own adverse effect. So few important drug interaction. This you can see even from the book also. So they are the drug which is going to enhance the sulfonylurea action, and few which is going to decrease. So decrease, enhance कैसे होएगा? Which is going to inhibit the metabolism. Decrease कैसे होएगा? Which is going to increase the metabolism. And another one is they are going to displace it from the protein binding. This is going to enhance. And here they are going to suppress the insulin release. Like these are the drugs which inhibit the release of insulin. You can remember this. This may be asked as a MCQ. Another one is which is going to synergize or prolong the pharmacodynamic action. Okay? Synergistic or prolong the pharmacodynamic action. They are also going to enhance the sulfonylurea action. Here the most important which I have highlighted, propranolol. It masks the symptoms of sulfonylurea induced. What is hidden here? कौन से symptoms? Hypoglycemia. Usually we say in diabetes mellitus patient, the propranolol, that is, or beta blocker, they are contraindicated. Why beta blocker? They are contraindicated in diabetes mellitus patient. Or why propranolol? Because in diabetes patient, if the person is taking any drug or if the person is on insulin, then what will happen? The most common side effect with the insulin is क्या है? Hypoglycemia. And what are the common side effect with the hypoglycemia? So there is, if the person suffer with the hypoglycemia, there is increased sympathetic nervous system, or sympathetic nervous system will be stimulated, and that is going to exert what? There will be sweating, there will be tremor. And if the person is taking sympatholytic drug like propranolol. This is a sympatholytic drug. So because of the hypoglycemia, whatever the sympathetic system patient is feeling, patient is not going to feel that symptom. That's why word here used mask. So propranolol, it masks the symptoms of sulfonylurea induced hypoglycemia. What are those symptoms? Like there will be sweating, there will be anxiety, there will be tremor, but the patient को hypoglycemia will not, the short-term symptoms will not be felt by the patient, and patient will go directly to the neuro symptoms. Patient may go directly to the coma. That's why propranolol or beta blocker, they are contraindicated in diabetes mellitus patient. So next groups is this insulin secretagogue, that is Miglitinides. We have two, repaglinide and natiglynide. So their mechanism of action, that is same. How the sulfonylurea group of drug they act. Now what is the difference between this and sulfonylurea group of drug? They are short acting. So their duration of action is 1 to 2 hours. Okay? Now they are going to take care of only, उसमें कितना था 6 to 8 hours. Lowest जो tolbutamide का था 6 to 8 hours. Otherwise 12 hours, 24 hours, more than 24 hours. इसमें कितना 1 to 2 hours. So 1 to 2 hours, that means where we can use this group of drug, it is used only in the खाना खाने के बाद जो होता है, what is that? Postprandial hyperglycemia, because it is going to take care of blood glucose level only for 1 to 2 hours. So any patient, if all person is all right and showing only this postprandial hyperglycemia, you can put the patient either on repaglinide or natiglynide, postprandial hyper. Or अगर patient is already taking some anti-diabetic drug, but still the fasting blood glucose, that is all right, glycosylated, that is also okay, but there is a not the glycosylated, fasting blood glucose, that is all right, but postprandial hyperglycemia, that is seen. And then what we will do, we can put that patient on this Miglitinides. So Miglitinide, it is used as a postprandial hyperglycemia to control the blood sugar, and to we can use it as an add-on therapy with some other anti-diabetic drug. So it is not going to affect the level of fasting blood glucose level, and because it is going to take care of only postprandial hyperglycemia. But so if the person misses any meal, then there is no need to take this drug. So this is a repaglinide. So same way it is going to act, rapid onset before each meal to control postprandial. Because of the, इसमें important क्या है, usually sulfonylurea group of drug, they act by causing the release of insulin. Here also it act by causing the release of insulin, but action is short lasting, so hypoglycemia, that is also less. So there is a lower risk of the serious hypoglycemia with this group of drug. Okay? Side effect, headache, mild headache, dyspepsia, arthralgia and weight gain, that is seen even with this group of drug. So with the insulin secretagogue, I have finished sulfonylurea group of drug with both first generation and second generation. Miglitinides, that is over. Natiglynide and repaglinide. Then coming to the third one, glucagon-like peptide receptor agonist. Okay? We have two. So this is the one which we give by parenteral route or usually by subcutaneous route. So we have two, exenatide and liraglutide. So they are GLP receptor agonist. Now already I have explained this. What is the this GLP analog? So this GLP, they are incretin. They are the digestive enzymes which are released in response to, or gut enzyme which are released in response to the food. But they are going to act here on the receptor and causing the release of this insulin, but it is degraded very fast with this DPP4, dipeptidyl peptidase 4. This is the one which is going to degrade it into inactive peptide. So this action, they act for a very short enzyme. So we cannot use this GLP-1 and GIP. So we are using its analog, GLP-1 analog. So what is that analog? We have a exenatide and liraglutide. So how this exenatide and liraglutide, they are going to act? They are the analog. So they are not degraded, just like GLP and GIP, which has degraded very fast with this. So they are not degraded and they are going to exert the action in the same way. आपने exenatide दिया, they are going to act on the incretin mimetic receptor. They are going to act on the GLP receptor. So in the same way, it is going to cause the release of insulin. So that's why this group of drug, this also comes under किसके अंडर आती? इंसुलिन secretagogue. And same dipeptidyl peptidase 4 inhibitor, what they are going to do now? Exenatide and liraglutide, they are GLP analog. They are going to act this way. Now, this is degraded by GLP. The endogenous GLP, they are degraded by dipeptidyl peptidase 4 enzyme. Now, if I give DPP4 inhibitor, this is going to inhibit this enzyme. ये enzyme अगर inhibit हुआ, then there is no degradation of this. This is going to act and they are also going to cause the release of insulin. So that's why they also comes under insulin secretagogue. So under the insulin secretagogue, we have 4 group of drug. One is parenteral and 3 are oral. Parenteral हमारे पास कौन सी है? We have a parenteral GLP-1 analog exenatide liraglutide, whereas oral we have insulin secretagogue में और क्या आते हैं? Sulfonylureas group of drug, Miglitinides and DPP4 inhibitor. Now, exenatide and liraglutide, they are GLP analog. We got it, exenatide, from the salivary gland venom of Gila monster. It is going to activate GLP-1 receptor. Okay? So, this is relatively resistance to cleavage by DPP4, whereas endogenous GLP, that is degraded very fast. Mechanism of action, already I have shown how they are going to act. So they are going to act in a same way. How the so GLP, what exactly this endogenous GLP they does, and same way this exenatide. So they are, number one, it causes the release of insulin by acting on the beta receptor, beta cells. Sorry, not beta receptor, beta cells. Number two, it inhibits glucagon release by acting on the alpha cells. It delays or slows gastric emptying. It stimulates the satiety center, the brain. Then it is going to cause the proliferation of beta cells, pancreatic beta cells, and decreases its apoptosis. That is programmed cell death of the beta cell. So this is very important action which is exerted, because this is the drug which is going to decrease the degradation of the beta cells. So disease modifying action, that is also seen with the exenatide. So this is how, what is the mechanism of action of exenatide? So it stimulates the satiety center. A patient को क्या है, there will be loss of appetite. It slows the gastric emptying. Patient will always feel the full. So this is mechanism of action of exenatide. And same way DPP4, their mechanism of action, that is also same. It also causes the release of insulin. It is going to inhibit the degradation of endogenous GLP. We'll see in the next slide. So we give it, because it is a peptide, high peptide, we give it by subcutaneous route or parenteral route. Duration of action, half-life, itni duration of action, that is 6 to 10 hours. We give it by subcutaneous route, and this is approved in 2005 as an add-on drug therapy with the other oral antidiabetic drug or with other antidiabetic drug. So exenatide, the most important is already I have told, because it is going to stimulate the satiety center, so there will be decrease in the acute pancreatitis. Okay? And hypoglycemia, that is rare, and only if we are going to combine with the other drug. And the most important side effect, that is the acute pancreatitis. This was asked as a MCQ. Now liraglutide. Okay. Now liraglutide, the only difference is it's a duration of action. It's a longer acting. Otherwise, rest of the things they are same. And because this also causes there is decrease in appetite. इसको क्या है? This liraglutide, it is also marketed as an anti-obesity drug. The loss of appetite that is seen with this drug, and it causes the loss of weight, and it is, apart from the anti-diabetic, as a separately, it is approved as an anti-obesity drug. This is the difference between liraglutide and exenatide. Next is DPP4 inhibitor or dipeptidyl peptidase 4 inhibitor. So already I have told how they are going to act. They are going to, so इसमें आपके क्या आते हैं? Sitagliptin, vildagliptin, alogliptin, tanagliptin, we have linagliptin, all these group of drugs. So they are going to inhibit the enzyme DPP4. By inhibiting that enzyme, it is ultimately this sitagliptin and vildagliptin, they are inhibiting this enzyme. So they are going to increase this level indirectly, the endogenous incretin level that is increased with the DPP4 inhibitor. By increasing the action will be same, just like this. But the only difference with the sitagliptin and vildagliptin, they causes the release of insulin and inhibit the release of glucagon. लेकिन इसका gastric emptying and on the satiety center, it is not going to exert any action on this. No action on the gastric emptying or no action on the appetite. Only it is going to cause the release of this insulin and decrease the glucagon release. So how this is sitagliptin, and the only difference between all these, the few they are going to bind with DPP4 simply, and few they bind with the DPP4 and other DPP4, they are not that much selective and they are bind covalently. So ultimately whatever gliptins they are there, they are going to lower fasting blood glucose as well as postprandial HbA1c, that is equivalent to metformin, and we give it by oral route. This is how this drug mechanism of action ने बता दिया. So we use it as an add-on therapy, and the most important side effect with this group of drug is nasopharyngitis because of the elevated level of, और ये इसका जैसे उसका acute pancreatitis exenatide का, इसका क्या है? nasopharyngitis rarely produces the hypoglycemia. Same exenatide and liraglutide, the hypoglycemia that is less given netiglenide, जो जितने भी आपके insulin secretagogues, maximum hypoglycemia that is seen with the sulfonylurea group of drug. ठीक है, उसके बाद आपकी ripaglenide, miglitinides, that does not show the hypoglycemia because of their short duration of action. Exenatide, liraglutide, they also do not show this one, and even this group of drug, they also rarely produce hypoglycemia, only when we give it as an add-on therapy. Same vildagliptin, this is going to bind with this enzyme covalently and it is less selective. So this is the few important points I have told about the insulin secretagogue. This classification again I have taken from the same book by standard textbook of pharmacology by K.D. Tripathi. So here you can see oral anti-diabetic. Here what they have written oral, because I have covered even parenteral. In this classification you won't be able to see exenatide and liraglutide or GLP-1 analogues or agonists. So that's why word oral anti-diabetic. But this is very important question. Classify anti-diabetic drug. You must see oral hai, anti-diabetic hai. If it is a oral, then you can use this classification. If it is an anti-diabetic drug, then you have to write even parenteral. So far I have covered this, the drug which is going to act by enhancing the insulin secretion or insulin secretagogue. उसमें आपके क्या है? This side it is oral, and I have covered parenteral also, that is GLP analog. And oral में आपके क्या है? Oral में you have a the drug which act by blocking the ATP sensitive potassium channel and DPP-4 inhibitor. With the ATP sensitive potassium channel, we have sulfonylurea, Miglitinides. So this is over, this is over, this is over, this is over. So in the next video, I will be covering rest of the anti-diabetic drug. Now, look at few of the important MCQ just to strengthen the topic, because this topic it is very important. Sulfonylurea drug, they act by. Now the first choice is reducing the absorption of carbohydrate from the gut. Second one is stimulating the beta islet cell of pancreas to release insulin. 3 is increasing the uptake of glucose. In the peripheral tissue. 4th is they are going to act by reducing the hepatic gluconeogenesis. Yes. So correct choices, they are insulin secretagogue. So they are going to stimulate beta islet cell to release the insulin. Now insulin release due to, see how the various type of question they can be asked from the insulin secretagogue. Insulin release due to closure of potassium channel is seen with, that means you must know the name of all. Natiglenide, that is Miglitinides, definitely it is going to act. A-carbose, exenatide and sitagliptin. Yes, what is the right choice? This is the Miglitinides. This is GLP-1 analog. This is DPP-4 inhibitor. Yes. So all they are going to act by closing ATP sensitive potassium channel and cause a release of insulin except A-carbose. Which of the following does not cause the insulin release? So the same thing can be asked in a different way. We have rosiglitazone, natiglenide, glimepiride and tolbutamide. So this is a Miglitinides. Natiglenide आपका क्या है? It is a Miglitinide और ये क्या आपके sulfonylurea group of drug. So they act by causing the release of insulin. So इसमें हमने क्या पूछा? Does not. तो correct choice is this A, rosiglitazone. Next, which of the following is not a starting criteria for sulfonylurea therapy? हम कब है कि हम नहीं शुरू करते? Total pancreatectomy, non-insulin dependent diabetes mellitus, diabetes after 60 years and none. Non-insulin इसमें करेंगे 60 years के बाद, तो भी हम the person is obese, then none. Sorry, if the person weight 60 years अगर patient का weight नहीं, because it is this sulfonylurea group of drug, they cause the weight gain. Then for the action of sulfonylurea group of drug, we need 30% intact or functional islet. So this is the correct choice, which is not a starting criteria. If there is no pancreas has been removed because of the surgery, we cannot start this sulfonylurea group of drug. Second generation sulfonylurea group, sulfonylurea drugs are all. Now you must know second line ये भी है आपकी, ये भी है, ये भी है. This one is a first generation. Flushing is common in patient taking which of the following oral hypoglycemic drug? With alcohol, flushing is disulfiram like reaction. So first generation में आपकी दो आती हैं, tolbutamide and chlorpropamide. So in a adverse effect, I've specially told about the chlorpropamide. It shows cholestatic jaundice. It shows disulfiram like reaction. It causes the increase in ADH release. Now all of the following statements, they are true about natiglenide. So this is a Miglitinide. This is insulin secretagogue, except they decreases the postprandial hyperglycemia. Yes, it is a short acting, so इसको use इसलिए करते हैं. Hypoglycemia, it is less common than with sulfonylurea. This is also true. It decreases the insulin resistance. So this group of drug, not. It act by releasing the insulin. This is a true. So this is the correct choice is this. It is the choice is C. So that's all about the insulin secretagogue. If you have any query, you can ask your query in the comment section. Thank you for watching my video.